Dr. Scott-Blair, who is not a stranger to the Art-Vic community. He's been affiliated with us for many years. And Scott has had a lot of experience, not only in Australia, but also has a lot of, is up to date with a lot of international research and developments in terms of theory and medications and so forth. So we actually asked him to come along and give us a bit of an update of what's happening and what's the latest. So Dr. Scott-Blair is the Medical Director for the Anxiety and Depression Program at the Melbourne Clinic, and he's going to provide an overview of the latest updates and developments in terms of treatments, medications and options for anxiety, not just OCD specifically. So please welcome Dr. Scott-Blair.
So it's forward and back.
That's it.
Is there there's a pointer as well? Oh,
Yes,
there is. Okay. Thanks, Michelle. Thanks for the invitation to be here. Happy to come back and talk at this meeting again. And particularly this place because I remember spending my first night as a married man here in 1987. You can remember those days too? Yeah, yeah, it was called the Rockman's Regency in those days. But yeah, a nice place. Yeah, so I'm going to talk on an update. Now, Michelle's got it slightly wrong, not due to her, due to me, because I have focused this probably more on OCD than on other anxiety disorders. I have a little bit at the end, which, if we have enough time, I can touch on other anxiety issues or not. Are we still going with the original timings, roughly? Yeah. So about 40 minutes and a few minutes?
If you like.
Okay, yeah. Just talk a bit slow. All right. Now, I'm a psychiatrist, but I work prescribing medications, but also doing cognitive behavioural treatment, and my interest in the last 10 years has moved probably a bit more to more intensive work, inpatient work at the Melbourne Clinic. We have a small inpatient residential program there, so I'm going to talk a little bit about that stuff as we go on. No? That's supposed to go forward, isn't it?
Yeah, it's gone up. Yep.
Oh, there we go. Oh, it goes back on it. Okay. So, these are the areas I'm going to talk about, and as I said, I'm going to talk using OCD as the sort of the main area, but I'll sort of address other anxiety disorder issues as we go along to some extent. So, I'm going to talk about how we're better at recognising it now. I'm going to talk about some changes in how we understand OCD particularly. I'm going to talk a little bit about the newer Cbt approaches that we're using. I'm going to talk briefly about how it crosses over with other things. And then I'm going to spend maybe a bit more time on 6 and 7, which are the changes that to treatments with medications and with cognitive behavioural changes. And I'm not going to steal Jennifer's thunder much at all, because she's talking to you about NAC after I finish. Okay. All right, so let's start with this. Now, I disobey all of the general rules about PowerPoint presentations. I always put too much on my slides, so don't feel like you have to rush to write it all down. I'm quite happy to send you a copy of the slides at a later stage. In fact, I might. Well, you've got a copy of them, so you can contact Michelle or me if you want to have these in their entirety. So this comes from an article I wrote with a GP about trying to help GPs recognise OCD particularly more, and these are the sort of things that we were suggesting that people need to be aware of, because we know that about 2% of the population have OCD, but probably, we don't really know precisely, but we think that probably maybe a third of people with OCD are actually recognised and appropriately treated. So we've still got a long way to go in actually picking up all people with OCD and providing assistance. Now, part of that is because GPs, psychiatrists, psychologists are, to be frank, pretty poor at picking up OCD, and we don't always ask the right questions, which is what this is about. The other part of it, obviously, is that some people with OCD and other anxiety disorders too are anxious about talking about these things. Now, 40 years ago, which is before I started, by the way, that was because people were scared shitless that people were going to think they were crazy and toss them in psychiatric hospitals. Now I think it's partly stigma issues, it's partly because there's an uncertainty about whether we have treatments that are going to be able to help. And I guess what I'm going to say as we go on is that we do have treatments that can help. So anyway, these are the sort of things that I'm telling GPs to think about. And none of this will come as a surprise to you, except maybe some of the other things. Anxiety-provoking thoughts, compulsive behaviours, other anxiety disorders. So I see a lot of people, and this is where things like social anxiety is relevant. In our hospital program, we have 8 people with OCD who come in and do our program at any one time, and I'm going to say that probably half of them, or more than half of them, have significant worry and social anxiety as well that they haven't been aware of. And I have about probably up to 10 patients who I really love, who I see in my practice, who I'd love to go in and do the hospital program, but they're really scared about going into a group setting and actually having to talk about their stuff in front of other people. And the irony, the issue here is that most people, when they go in there, and most of the people that we see who go in for the first time have never knowingly talked to someone else with OCD in their lives, and they go in there and they see 7 other people with OCD, often with other anxiety issues as well, and that's a huge part in helping them start the process of getting better. And again, this is sort of more my suggestions for GPs. They should be thinking about resistance to anxiety disorders. I've seen countless people who've had lots of treatment for depression, but the doctors and psychiatrists are probably nearly as bad at this as GPs are. They haven't recognised that the reason people are getting depressed repeatedly is because they have an underlying anxiety disorder, which either they haven't talked about, or they've given the GP a few little hints, but the GP's just ignored it and gone on. And again, psychiatrists are, as I said, nearly as bad with this stuff. Okay, and again, these are the questions that I want people to ask. So again, they're fairly standard stuff. Do you check? Do you wash? Do your daily activities take a long time to finish? Do you have to do things over and over again? Do you have a special order? Are there things that, is there a thought that keeps bothering you? Etc, etc, etc. So, as I said, this is the first thing we're trying to do, and I think we're getting better. I think we're picking up more people with OCD. People are talking about it more, we're talking about it more, and there's sort of a flow-on effect in that regard. So there we are. Actually, can I ask, there was one thing I wanted to ask you all, as a group, well, how many, roughly, you don't have to be, how many people here are treaters or therapists or counsellors or that sort of thing? Okay, lots. And how many people are sufferers? The rest. Okay, all right. Michelle, is this a test? Do I have to press this button repeatedly, do I? Press button repeatedly.
Left or right?
Okay, all right. Okay, I might just do it from there. This thing's working, though. All right, so this is the second area of interest for today, and this is an area. This is not within a couple of weeks ago. I was in the US at the International OCD Foundation Conference, which is an OCD organisation, support group organised in the US. and I gave a talk there, and I'll touch on a little bit of that later on, but this is the talk from the talk I gave last year at this conference. And this is about, I've been working in OCD for 25 years or so, and even over that time things have changed. And so we see people with concerns about contamination. That's when I talked to a fellow who I'm sure was a member of this, this group. He's died subsequently, but he'd had OCD for 50 years, and he described this sort of change over the years. When he first had OCD, he worried about getting syphilis. It was all about sexually transmitted diseases. And that gradually over the years changed, and that was him personally. But that's actually how it's worked as well. And the interesting thing is that fear of HIV, which 10 years ago was probably one of the most important OCD symptoms relating to contamination, is now much less common. And the obvious reason is because we have a lot of treatments for HIV now that mean that people with HIV essentially live pretty much normal lives. So other changes, contamination OCD, people now tend to just hate the feeling of being contaminated rather than worrying as much about getting sick or transferring it to other people, and that's a change in the last 10 years or so. Issues with harm, so people still do worry a lot about causing harm to others, but now it's sort of changed a little bit. And I think this relates to the emphasis we've been seeing in schools on bullying and trying to stamp that out. So now a lot of people with OCD that I've seen are worrying that they're going to they fear that they might cause offence to other people, or they might fear they might bully people, unintentionally. This is a big area here. Lots of people obviously are worried about security with mobile phones. There's a whole issue about, obviously, about Facebook and Instagram and those sort of areas, which is what we talked about at the conference this year. We see paper still, but we see computer hard drives, because people are now hoarding emails and hoarding electronic stuff, and that's what they're hanging on to now. I mean, they hang on to paper as well, but we have that additional issue. So this is from our talk from last year, and these are the things that we're I did this talk with my friend Chris Mogan, who's a psychologist at the Melbourne Clinic. These were the things that we're sort of pondering will influence OCD content over the next 10 years or so. I've already seen people who worry about their effect on climate change. I have a patient who used to worry that it was very important that she needed to recycle milk bottles. But this is from a few years ago when the drought was bad. She was worried that she had to clean out the milk bottles, but that would involve her using water, and she was worried about wasting water. So she had this huge dilemma of, I should be recycling, but on the other hand, I could be wasting water at the same time. And that sort of, those horns of a dilemma is a pretty common issue. I talked a little bit about this, computers and phones, new illnesses, schools and bullying, ageing, obviously, migration and refugees. I'm just thinking about all the issues that are sort of current at the moment, and as I said, I'm already seeing a few people that come along talking about these sort of things. And the talk we gave last year at the conference in the US focused on the fact that contamination for my treatment lifetime, and probably for my lifetime, will probably still be the most important OCD symptom, or the most important OCD cluster of symptoms, let's say. But the interesting thing here is that the first recorded cases of contamination-based OCD date from about the 1860s, 1870s. Prior to that, it did not exist because no one cared about washing their hands. Okay, we barely discovered bacteria, we had no clear history of or understanding of how illness was created. Prior to 1870, most of the cases of OCD that were reported are all religious cases. They're all about scrupulosity. And if you go back into history, you'll find a lot of cases of famous religious people. Martin Luther is the one that comes to mind, who almost certainly had OCD about religious type of issues. Okay, so Okay, so this is my next thought. So I've already talked about how we're getting better at picking it up. We're seeing a change in the obsessional content, so that's the intrusive thought that you get first. We're also seeing some, probably not changes in this area, but just better recognition of what's going on here. So these are the classic compulsive behaviours that people do. And these are the behaviours that we're trying to make sure we pick up on. So my last line there is what I keep trying to sort of emphasise here. I personally don't believe, you've all heard the term pure obsessional disorder or whatever you think. I don't think it exists, because I think everyone who has, inverted commas, pure O, does do compulsive behaviours, but mostly they're in the head. They're all these sort of things. So they have special words, numbers that they need to do, they have little prayers, they count, they make lists, and this is the big one, people who go over what they've been doing to make sure they haven't caused harm. And so, you know, we, in our hospital program, we see people coming in with, you know, pure O all the time, and, you know, our first task always is to see, you know, where they fit in this area. How many of this, what sort of stuff do they have here? Because the one thing we know about exposure treatments, particularly in OCD, is that they will not work if the person continues to do compulsive behaviours. And compulsive behaviours, as I said, have become more and more subtle, and they're, as I said, they're done in the person's head. So, you know, whenever we see someone, I mean, I had a patient who has done really well subsequently, but her fear was that she would harm people. And what she did originally was she would walk past someone, feel like she must have hit them or something, and then almost chase after them and, you know, almost ask them if they were okay. A bit disconcerting, I would imagine, if you see someone running after you and, oh, okay, fine. And then it sort of became more and more abbreviated, and what it got to was a point where she would walk and then she would stop. And she would have to do a little mental ritual in her head, and then she would move on. And the task of her husband, who we engaged in the process, was to just give her a little push so that she couldn't complete her mental ritual, and we were doing response prevention, as we say, in that context. All right, so this is the next area. Now, this isn't particularly new, but this is stuff that I like to talk about on a pretty regular basis. This is the way we understand how OCD works. So there's a thought that triggers it off, get an intrusive thought, there's an appraisal, or in essence a worry about how bad that intrusion is, anxiety, and then a compulsion. This is sort of how it really works, and you know I have, you know, a dozen of these different sort of models to try and explain how a person's OCD works, and this is what we're trying to do when we start off in our program. We're trying to understand how people's OCD works, because we need to explain it as much as we can in order to try and make some changes. This is one actually we used for our recent talk on social media issues and the like. And this is a patient of my colleague Chris's, who would have intrusive thoughts about what her friends were doing, and a real urgency would develop about her need to know about this. She struggled with uncertainty in that context. She would get very anxious, and then she would have to repeatedly check. So that's just an illustration of how it works, but in essence this model is pretty much what we use for all of our patients. It's fairly accepted worldwide. Different people will focus in different areas. Some people will focus in this area. We tend to not do so much in that. We tend to do exposure therapy, which focuses a bit more down the track. So, all right. So this is my next point, and this is about the sort of the crossover between OCD and other conditions. And this is an immensely complicated slide, and I have to sort of translate most of it for you. The reason this is here is because some of you may know that our classification system works on what's called the DSM system. DSM-5 has been released recently. This is what the American Psychiatric Association thinks, are psychiatric conditions. It's always pretty controversial, and it's certainly controversial in this iteration because they have said that OCD is not an anxiety disorder anymore, believe it or not. It's now on its own. So we have anxiety disorders, and then a separate category is anxiety and related disorders. And these are the related disorders. And as you can see, this is actually wildly over-inclusive, but it does include some things that we would have always thought were associated with OCD pretty clearly. So Tourette's syndrome here, trichotillomania, pathological gambling, self-injurious behaviour maybe. What else? Well, they're the common ones. I mean, we see an overlap sometimes with people with schizophrenia. There's a significant argument that some of the eating disorders might be sort of unusual, and certainly I've seen people who present with what looks like anorexia, but actually it's OCD underneath it all. But we know there's quite an overlap between, there's a lot of people with, usually most commonly young women with anorexia who have some very particular compulsive behaviours in, say, the way they prepare food, the way they cut it up, the way they serve it, all those sort of things. So their compulsive behaviours are clearly related to their anorexia issues, but they're clearly, compulsions as well. And then there are people who have both eating disorders and have clear OCD stuff as well. So that combination is pretty well recognised. There's all these neurological conditions. In America, they're really interested in what's called PANDAS, which is a sort of a sudden onset form of OCD that is related probably to an immune reaction to a streptococcal infection. And that's SYD means Sydenham's chorea. You'll see there they've got autism and Asperger's disorder as well. That's, again, sort of a bit unclear. That's probably casting the net a bit too wide. Anyway, my point is here that OCD now exists in its own category, and with these sort of conditions. Whether that remains, who knows? So, I guess the other one that probably should be there if it isn't, it's not really. Skin picking, conditions, excoriation disorders, that sort of thing, which they're looking at, and I'll talk about actually a little bit later on, and there's thought about how those are related to OCD as well. All right, so about OCD and the OCD-related disorders with regard to the medication side of things. This is the area that they've been best studied at. This is straight up hot off the presses from this year's OCD Foundation Congress in Chicago 2 weeks ago. So this is pretty much up to date. Now, having said that, I've got to say there's only a very limited bit of new information there with regard to OCD. So what it says is that SSRIs, so this is the selective serotonin reuptake inhibitors, remain the first line. So this is Prozac, Lexapro, Zoloft, Arapax, that group. I can give you the other names if you want, but they're the common trade names. So fluoxetine, those sort of drugs. SNRIs, so this is the next group of antidepressants that we tend to use. Venlafaxine, which is Effexor. Desvenlafaxine, which is Prestige. Cymbalta is another one. There's a handful of drugs here that work on both the serotonin and the noradrenaline systems. And CMI is the oldest drug in this area. It's clomipramine, which is a tricyclic drug, which an antidepressant that is still known to work for OCD. We don't tend to use it first up because of its side effect profile. So there's nothing new there. That's the way it's been now for 25 years, I guess. We will sometimes, and this I'm just talking about medication treatment. The point to emphasise here is ERP, exposure and response prevention, which is the main CBT psychological intervention, remains the best thing to add to medications and probably the best, most effective treatment of all of them anyway. The research would suggest that ERP is probably around about twice as effective as medications anyway, so it's obviously the way to go. So we often add in atypical antipsychotic drugs. These are things like Olanzapine, Ketamine, other drugs like that, often in very small doses. We'll add those into the SSRIs in the hope of getting a bit more of a boost. That works in some occasions. The thing we're really interested in, and Gina's going to talk about NAC, N-Acetylcysteine, which I keep saying it's an amino acid, isn't it? Yes?
Derivative.
Yeah, derivative of an amino acid, so it's natural-ish. Natural-ish. Yes, sort of natural. And these other drugs are actually drugs that have been developed for use for Alzheimer's disease. There's a little bit of evidence that perhaps adding memantine and riluzole into pre-existing antidepressants may be helpful a bit here as well. And we're still learning about drugs that facilitate extinction learning. What that basically means is you take these drugs and they may well make your exposure therapy work better or work more quickly. And we had a little burst a few years ago with this drug, D-cycloserine, giving it to people before they did exposure therapy, and there was some research to show that that would tend to make people respond better and more quickly. It sort of died a bit of a death, I have to say. It hasn't really proved to be that successful. Ketamine remains a fairly controversial drug. It's a drug that some of you may know is used a lot by anaesthetists. It's used for pain relief. It has a very quick action. There is some evidence to show that you can give it, particularly intravenously, and that maybe over the next week people will, their OCD, depression, other anxiety disorders will be significantly reduced. And it may well be you have about a week or 10 days window to do some intensive work using maybe exposure therapy during that time. I suspect ketamine is not going to be, the breakthrough that people are saying, because it's just too complicated to use it, and the restrictions on the drug are going to be too limiting. But the interesting thing here is that this drug, these drugs are all looking at a different transmitter system. They're looking at the glutamate system. In the past, these drugs look at serotonin. These ones look at serotonin and noradrenaline. So we're looking at something a bit different here, and that may be of benefit in the long term. Okay, so body dysmorphic disorder. Okay, so briefly, these are people who have thoughts that are probably not delusional, but they're certainly overvalued ideas about their appearance, and it can be nearly anything. Their nose is too large, or their ears are too big, or regardless. I've talked to a few people who worry about not being tall enough. There's a myriad of issues here. Essentially, this is what we do, the same sort of thing. We use the same drugs here. We gain, augment. Buspirone is a drug that really isn't available in Australia anymore, or not easily anyway, so it probably isn't the answer here. It's a drug that was only used for anxiety. It does seem to have a special benefit in this condition, but I have a feeling we're not going to get it back in Australia very easily anyway. It's a serotonergic drug that's usually added to these ones up here. All right. So the sort of the common pattern I wanted to emphasise is we usually use an antidepressant type medication, and then we may add something else in. The more important thing again is CBT, and we have a couple of detailed Cbt protocols developed in the States. Well, actually, sorry, this is an American one. David Veal is English from London, and these are sort of available fairly freely now, and are worthwhile looking at for therapists probably in trying to treat body dysmorphic disorder. So again, not massive differences in the treatment here, but an emphasis probably more on getting to CBT more quickly in some ways. Hoarding. Now, hoarding has forever been seen as a condition that is associated with very poor treatment response with medications. And the problem has been that the people who've looked at this in the States recently are saying that, well, look, the trials we've had up to now with hoarding, looking at medications in hoarding, are not valid because they've basically been looking at people with OCD who have hoarding as well, and that's not really accurate. The scales aren't that good. The focus has all been on the OCD, and the hoarding's been sort of a side issue and hasn't been well addressed at all. What Sanjay Saxena is saying is that we probably still start hoarding with CBT, and we have specific CBT approaches. The Buried with Treasures workbook is the way to go in most cases. There are group-based things. There are specific CBT approaches that look at the person's difficulties, with acquiring things, difficulties with discarding, and all of the issues people have with wanting to hang on to their stuff. You know, what we know with hoarding, and this is part of the reason why hoarding's been separated from OCD in this last DSM, and it's largely because people think that the way people think about their hoarded materials is very different from OCD. And certainly people with hoarding who I've seen, if you were to say to a person with OCD, if I had my magic wand here and just donged you on the head with that and I got rid of all your OCD, they would say, do it now. People with hoarding would be a little different. If you said that, they would say, just let me think about that for a couple of days, or maybe a week, or maybe a couple of years. And that's because the idea for them of getting better at throwing things out or discarding or recycling even is really difficult, because they have a real connection to their stuff. They really struggle with the idea of parting with it. It's almost like they're losing a part of themselves. And this is the other thing that Saxena is saying, is that perhaps people, if the targets with hoarding are more precise and we're using better drugs, or we're using drugs more specifically, we're going to get a better response. He had a decent response with venlafaxine, Effexor, and there's a couple of other drugs there that they've been looking at. And the last sort of area I wanted to talk about was skin picking and trichotillomania. And again, the medication trials here are pretty limited, to be frank. And again, it's been sort of assumed that people will not respond to medications if they have these conditions. All of that is being revised, but still the initial treatment remains more a psychological one with habit reversal therapy. These are the drugs that have been used: Olanzapine, sometimes NAC. There's a recent trial in adults showing that NAC is quite effective in this group. One of the thoughts is that probably at this sort of level, which is the number that we used in our trial that Gina will talk to you about in a second, and these other drugs may be effective as well, but you know, the research just really isn't there in this group. Okay, so that's pills. So I want to talk now a little bit about changes in CBT stuff, and I guess specifically in OCD we're talking about changes in exposure therapies, or the way we think about exposure therapies, because the evidence is pretty clear that exposure is the most effective treatment for OCD. Now, one of the Michelle Krasky, who works in Los Angeles but is actually from Tasmania originally, and will periodically come out to Australia to visit her relatives, I think, but she gives talks every now and then when she's here. Certainly worth hearing if she's in town. She's talked about, she's developed some new ideas, and it's focused on this thing called inhibitory learning. And basically, this is a sort of a lecture in itself in many ways, but inhibitory learning says that, to summarise it, what we used to think when we got people to do exposure therapy, so I'll use a more simple example. Let's say we're dealing with someone with a spider phobia, okay? So a lot of people, when they started getting worried about spiders, they had an event which made them highly anxious about spiders, and then their fear generalised, I should say, from that situation to a whole range of other related situations. And this is not the way OCD works, the way panic disorder and agoraphobia works as well. And what we used to think was if we did exposure therapy, we'd sort of get rid of all that fear that they would have about spiders. They would sort of unlearn it. And they'd go from thinking that spiders were dangerous to thinking that spiders were safe. Now, the evidence that we have now, in fact, is that our brain never really loses information. And so what we think happens now is that when you do exposure therapy, you can, by practicing exposure regularly, and it's a lot harder to get people to believe things are safe than to believe things are dangerous, but when we're successful in doing exposure therapy, people start to believe that spiders are okay. But tucked away back in their brain is still this fear of spiders. So what we're actually saying is they've sort of got both ideas in their head. And the theory seems to be, this explains why people who stop doing exposure practice go back and start to worry about things again, 2 months, 3 months, 4 months later. So that's sort of where we're at the moment. We sort of have this idea that people can retain ideas that situations are both safe and dangerous pretty much at the same time, and provided you're practicing your exposure, you're going to keep believing that you're going to be okay. If you stop doing it, you're going to go back to what you used to think. So that's sort of led to a bit of a shake-up with some of our approaches, and what we're thinking now is that, because what we used to do with exposure, we would keep doing exposure until the person could go into that situation and essentially feel no anxiety. So we were after fear reduction and what's called habituation. Nowadays we're not necessarily going to be as focused on that. I mean, we're in a bit of a sort of an interim phase here, because there's still obviously some benefit in doing exposure that gets people to be habituated, but we're also trying to think about these other ideas too. So with this sort of exposure, we're not necessarily trying to get people to be able to tolerate the situation with no anxiety. So we're going to focus on things like this. We're going to get them to just, expectancies is what they expect out of the situation. So we're going to, at the end of every exposure, even if they're still anxious, we're going to say to them repeatedly, now, you predicted this, and this is what happened. No catastrophe. And then we're going to do it again. No catastrophe. And we're going to keep going with that, and we're going to keep assessing, what happened, what was the worst case scenario, and did it actually work out? Our old approach, we would really just focus on trying to get them to repeat the task until their anxiety got down to zero. We try to put things together now, so we might get them to go into a situation, we might get them to have a bad thought at the same time, we might get them to have a cup of coffee beforehand so their heart was going a little bit. We might get them to imagine that the situation was going to be anxiety provoking as well. So we're going to put maybe a few different things together in our exposure rather than say we're just going to focus on this one thing. We get them to do exposure in different situations. So in our hospital program, we'll get them to do exposure in the hospital. We'll get them to do exposure outside the hospital. We might even get them to go, we're in Richmond, we might get them to go down to Bridge Road and walk down the shops there and do stuff in there. And for those of the people we have who worry about stepping on needles and getting HIV, we might get them to wander down Victoria Street, or even go for a little walk through the Housing Commission during the day. The word is that if people talk about how they're feeling, that might be helpful too. So if they say, I'm feeling really, really anxious about doing this, that might be helpful. There's some talk, and this, we haven't got to this yet really, is that if you do things sort of in the wrong order, with exposure, we tend to do things in a hierarchy. So we start from easy and build up to hard. Some of the new ideas are here, well look, let's go up to the top or near the top and do something tough originally, and then we'll come down and do something a bit easier instead of doing it, very carefully going up one by one. So. All right. I'm not going to really talk about this much because this is stuff that, to be frank, I only know a little bit about these sort of things, but these are some of the newer ideas. Mindfulness-based CBT has been around for a while. ACT has been around for a while. Compassion-focused therapy is sort of just making a bit of a move in the UK. I'm not sure it's going to be the answer here. Treatments designed to reduce anxiety sensitivity. Interceptive exposure remains a really interesting exposure treatment that we use for panic disorder and that we probably should be using more widely. One of the big issues that we have for a lot of people who come and do our hospital program is they're really anxious about getting anxious. And so we have to try and break down this idea that anxiety is horrendous, a disaster, and cannot be tolerated in any shape or form. And obviously doing exposure will certainly change that. But we have a lot of difficulty, not a lot of difficulty, we have a few people who we have to work really hard with to just even almost put their toe in the water and start doing this sort of work. Go on. This is an example of sort of new treatments and I guess combining treatments really. To be frank, this isn't a word I use, but a lot of people seem to know about this. Emetophobia is a condition, well, it's a symptom really. It's a fear of vomiting. And I've seen a number of people with this sort of problem. I think it doesn't really fit easily into any of these conditions. It's got a bit of this and a bit of this and a bit of this. And as a consequence, we've started treating this with a bit of a combination of things. So we do this interceptive exposure therapy, which is about exposing people to anxiety. And the easiest way to do that is to get people to practice deliberately hyperventilating and experiencing that feeling and then watching it settle down as they stop. There are other forms of interceptive exposure as well. So we do a bit of that. Then we do some more sort of classic exposure therapy. We get them to touch things and then spread. We get them to touch and then eat. We get them to do things without showering. We get them to... Most people with this problem have a range of foods that they don't like and that they won't eat and they highly are afraid of, and they're afraid of them. So what they're doing is they're not exposing themselves to vomiting per se, but they're exposing themselves to the context of vomiting. So everything that it means to be in a toilet, on your knees, chucking into the toilet bowl, which is a pretty distressing thought for pretty much everyone. But you could imagine that if you have a fear of vomiting, it's something that you probably need to be able to sort of get your head around. You need to be able to think about it. You need to be able to, in the worst case, actually tolerate that situation, which is the ultimate issue for a lot of anxiety issues, and panic's a perfect example. So many people I see with panic are very keen to never have another panic attack, and I can say that with 99% surety that you won't have another panic attack, but then we're always worried about that last 1%. So, all right, so the last little bit, how am I going for time? 10? Okay. Do you want 10 before questions or 10 include questions? 10 with questions? Okay. All right. All right, so I want to, the last few slides I'll just talk about some other issues here. This is and this is, to be frank, just a little bit of an ad for our hospital program. This is a study that was, or it's actually a meta-analysis, which means David Veal looked at all the treatment studies for people who were in hospital having intensive treatment for OCD, and he found 19 studies, and basically that was, they reduced 10 points is on this Y-box scale, so a 10-point reduction is a substantial improvement. Most of these went for 5 to 20 weeks. They had exposure therapy up to 20 hours a week, and these are the things that where people did well. if they were in a relationship, if they were employed. This is the interesting thing here. What it says here is that if your OCD is severe, you may actually do really well with this treatment. So it's not saying that severity is a block to you getting better. It's saying that sometimes, and this was a bit varied, some of the studies showed pretty clear evidence that people who had quite severe OCD did really well in this program. The last of the things that weren't associated with such good progress. Now, this is Nathan Dowling is one of the people who works in our inpatient program at the moment. He did a study as part of his doctorate, and this is a sort of a brief description of what we do. So we have people in for 3 weeks. We do mainly ERP. It's done in a group setting primarily. We do the 5-box model, which I showed you earlier, and a lot of ERP. We have 2 hours of exposure therapy within the group setting, and we have 1 to 2 hours self-directed. And these were our results, which are not quite as good as those other studies, but pretty close. And which is interesting because we're doing 3 weeks, they're doing on average about 10 weeks. And these were the things that sort of predicted. So treatment readiness, we had a sort of a measure to say whether people were sort of into it at the time. Certain obsessional beliefs were associated with people getting better. And I can talk to you about those later specifically if need be. Depression was usually associated with people not doing so well. Insight was important, people understanding how their OCD worked. And avoidance was not necessarily good. But that's the note again. That was what we found also, that severity did not improve with actually doing the treatment or subsequently getting better from the treatment. So I think that's an encouraging thing for us and for everyone. Okay, so these are the other treatments. This is sort of when what we've been doing hasn't worked so well. So I put our inpatient program up the top there. But these 2 things are also interesting. TMS is a new treatment that's been developed over the last sort of 10-15 years. It's been developed mainly for depression, and the research is all in depression, but there's thought that it may well be helpful by doing it in a slightly different way for people with OCD. That's being researched at the moment in Melbourne by Paul Fitzgerald at Victoria Clinic and the Alfred. Deep brain stimulation is sort of like the last resort, and this is, in years past we had brain surgery, psychosurgery for severe forms of OCD. So to be considered for this sort of therapy, you have to, in general, the rules are you have to have had OCD at a high severity for 5 years at least. You've had to have tried, I think it's 4 or 5 different medications and various combinations of medications. You have to have tried inpatient treatment in our program on at least 1 occasion, and you have to have tried ECT, shock treatment, as a trial to see whether there's no severe depression underlying it as well. So we've had 12 people, I think approximately, who've had deep brain stimulation for OCD in Melbourne over the last 5 or 6 years. The results are fair without being fantastic. We're seeing that about 40 to 50% of people are making really substantial progress, and this is people who had been struggling for many, many years previously, so it's an option we have. But it is a brain surgery, and basically, without grossing you out, basically the neurosurgeon drills 2 holes in the person's skull. They put electrodes down into a certain part of the brain on either side, then connect it up to a battery pack or a sort of it's the stimulator anyway. It's like you see with a pacemaker. It sits just here, and then the electrodes are stimulated sort of continuously subsequently. It's a big deal. It's complicated. It's costly. It's and as I said, it's the last resort we have. And the evidence overseas is that this is a benefit. at the conference I went to, the suggestion was that about 60% of people were making significant improvement, which is probably better than our results up to now, but that remains to be seen. The more we do, we might be getting better results, I think.
What part of the brain is stimulated?
It goes into a part of the brain called the Nucleus Accumbens, which sits just behind the frontal lobe. So if you were going to put it into, it would be about there. So that's your frontal lobe there. It sort of goes down and sits about in that area there, on both sides. Okay. Look, I might stop there. I've got a couple other slides, but that's the gist of it. The other things that I had related to stuff I've already talked a little bit about anyway. So you want to have 5 minutes of questions, or a couple of questions? So we have a bit of time for questions now. If you want to ask me anything, yep.
In this week, with the OCD and Anxiety Awareness Week,
Yes.
I've come across this several times, and that's the DSM stat, I believe, of 2% of the population is suffering OCD.
Yep.
Now, I challenge that because you brought up, you had a slide there which is OCD plus related disorders or symptoms.
Yep.
Is that 2% on that slide and those related symptoms?
No, it's thought to be 2% for people with OCD. So 1 in 50, we think 1 in 50 people have OCD.
Right.
And so the related disorders is additional to that again.
But how is that stat measured?
About, I'm going to say 15, 20 years ago, there was a rush of epidemiological studies done where, and there was about 10 of them done in various countries across the world, and basically what they would do is they actually go out and knock on people's doors and do a screening test for psychiatric disorder. So that's where the sort of the most sort of reliable numbers come from. So those studies give us, numbers like 2% OCD, 1% of the population schizophrenia, 0.5% have bipolar disorder, 1% have panic disorder, 5 to 6% have social anxiety disorder, those sort of things.
So I'm going to harp on it, right? And the reason I'm harping on it is on Wednesday, my wife and I saw the movie 8, which I highly recommend it. It is a brilliant insight into OCD on the higher end of the spectrum, right? Now I shared that with colleagues at work, and of the 10 that I shared, 8 turned around and said that we have OCD in some part of that spectrum, right? Now, that's why I challenge at 2%. I think we're more on the verge of an epidemic rather than 2%.
You're going to say it's more?
Yeah.
I was thinking you were going to say it was less. Well, yeah, look, I think it all comes, and this is all statistics, and frankly, that's not really my area at all, but there's an issue of, where's the cut point to decide this is disorder and these are symptoms. I mean, to be honest, what you say there always worries me a little bit because, there are so many people out there who, when I say, look, I specialise in OCD, they will often say, oh, I'm so OCD. And I say, yeah. Well, I don't actually say that. I say, under my breath, I say, yeah. And then they tell me about their stuff, and it's, they have some symptoms, but they clearly don't have the condition. Look, I work on the basis. I think that's a reasonable number, but because we're only really catching maybe a third of the people with OCD, it's going to remain an estimate maybe for a long time. But you are right in the other sense. There's clearly a group of, and I'm going to say maybe another 5 to 10% of people who have symptoms, and in a strict sense they don't sort of qualify, but sometimes those people get need help for that particular issue anyway. So yeah, it's that plus more. Yeah.
What age do you start to possibly see OCD traits? So children?
Almost as early as you could imagine, really. There's if you take histories, you will find, some people will describe symptoms when they were 4 or 5. More commonly, it becomes more consistent a bit later than that. But when I take a history of someone with OCD, it comes to me when they're 25. When I go back, they'll normally say that they maybe had symptoms consistently for 7 or 8 years. But even before that, they had a few symptoms when they were 14, and they had something when they were 10, and they did this little thing when they were 6 or something like that. So probably from the disorder point of view, we're talking about it coming on more sort of mid to late teens, but there is no doubt that there are a number of people where it comes on much earlier than that.
Can triggers set off more high severity, death of a family member? Or
Oh yeah, for sure. Yeah, look, my view is that OCD is, we talk about these things as being biopsychosocial. I think that pretty much everyone with OCD has a genetic predisposition, and that when it comes on is determined by stuff in the environment, whether it's family stuff, whether it's sort of stresses, or whether it's sort of major traumatic events like that. And I think that determines when it comes on. I don't think, to my mind, if that person, if they hadn't had that thing happen then, they might have had something else happen 5 years later, and that might have been when it actually started, in a sense, or when it became bad anyway. Look, the thing we know is that one of the thoughts actually is that social anxiety, so shyness and all its sort of more severe forms, may be the thing that starts most early in kids. And the thing that I think I suspect still missing is how much social anxiety there is in schools. And it comes out in all sorts of ways, with people not wanting to sort of say things in front of the class, absenteeism, all that sort of stuff. And there's some evidence that that shyness and social anxiety might start really early, like in even kindergarten sometimes, and it might be a bit of a forerunner for other things subsequently. And certainly that sort of combination of social anxiety early, OCD developing maybe 5 or 10 years later is sort of, very much an issue. Yeah?
What's the latest research on Pregabalin with generalised anxiety?
I don't think there's any new research. Did everyone hear that? Probably not. What's the research on Pregabalin? And the answer is that's Lyrica, I think, isn't it, the other name? Yeah, I don't think there's any new research on it. The company that makes it have really focused most of their energies in treating people with pain. And there really hasn't been much new research in its use in anxiety in the last 5 years anyway, maybe even longer. I can't say I've found it to be, a major, drug in treating anxiety particularly. Partly because so many people get side effects at relatively low doses. I've found some people who've been able to sort of tolerate 25 twice a day or 50 twice a day maybe, but some going beyond that, they really struggle.
What are the side effects of that?
Sort of dizziness and sort of headache and those sort of things as much as anything. Yeah.
Just another drug, you mentioned valdoxin, which is a melatonin limiting. What's your view on that?
So the question was about valdoxin or agomelatine?
Yeah.
I think it's a helpful drug for people with depression. I have prescribed it for quite a number of people with anxiety and mainly OCD, and I haven't found it to be beneficial, particularly for the OCD side of things. But I think if you're getting a benefit from the mood side of things, it's certainly it's worth persisting with. It has one big advantage, and that is that it can be easily added to a different medication. So, if we have someone on a serotonergic drug like Prozac or something like that, we can add a little bit of valdoxin in quite easily without any real fear of interactions. But yeah, I haven't had major. It hasn't sort of knocked my socks off in that sense. Sorry, I'll ask. Yeah.
People attending your clinic, would they always be on medication as well as?
the question was whether people at our clinic are on medications. The answer is, so this is our inpatient program. Yeah, probably, I'd say about 80% are. There are always a few, there are always probably one or two in each program who aren't. But the thing probably to say is that, and I didn't say this before and I probably should have, is that with those medications for OCD, we see that, I mean, the evidence is solid over many years and many trials, and that is that, let's say 2/3 of people get benefit from SSRIs, for example, for OCD, and that means 1/3 don't. And I think most of the people we see in our program are at the third who don't get much benefit. So now there's a qualification here, and that is that these drugs, SSRIs, have differential effects on OCD and depression. And so you can take a drug like Prozac or Lexapro or something like that and tell me that it's not helping your OCD, but it might still be helping depression to some extent. But yeah, so mostly they do. Most people who come in have tried medications, and mostly they're pretty disappointed with how they've gone. Yeah?
Any more evidence regarding the connection between, let's say, pathological gambling and OCD?
I don't think there's more evidence. I think there's
Connection?
Well, look, it's included in that crazy diagram, and it's one of those sort of, you know, impulse control disorders, and there's a sort of, you know, there's a putative association between all of those conditions and OCD, but it hasn't really been well researched, I have to say. I mean, having said that, they do respond, those sort of things sometimes respond to SSRIs, and you know, there are some sort of psychological CBT treatments that borrow a bit from this sort of exposure therapy that do help. Sorry.
Is that inpatient program available to people without private exposure?
Effectively, no. I mean, it is, but I would be. I'm not asking people to spend. We have people occasionally who come from. We have had a couple of people from internationally, and they charge them $800 a day or something, which is pretty crazy. The thing I would say to you is that and this is still not as widely known as it should be, and that is taking out private cover. I mean, the insurance companies have a system where if you have a pre-existing condition, you can't use the insurance immediately. But it's 12 months for most conditions, but for mental health conditions, it's 2 months. And I have had a number of people who I've said, look, take out cover for 6 months, you'll have to wait 2 months, then we can get you in and do the program. We can probably get you in on a second occasion and do the program again. We can get all that done within that time, and then you can decide with the cover. And that's going to cost, I'm guessing, it's going to cost about $120 a month or something for a single. You want me to stop, or you want me to? Yeah, I've had a pass.
Keep you going, but
Oh,
just
thank you.
something said. Thank you very
Thank you.
much.